Good evening, ladies and gentlemen, and welcome to tonight's Wound Care Today Facebook live from Milton Keynes at our national conference. Thank you for joining us. Tonight's event is called Microworld, a new way to learn about wound exudate. And our amazing speaker who's here with me now is Siobhan Mccoulough. Good evening, Siobhan.
Hello, Ed.
How are you?
I'm very well, thank you.
Good. Enjoy today?
It's amazing. It's so good to be back again and just really good learning platforms.
It's been quite surreal.
It has been surreal.
But brilliant.
Yes.
So thank you so much. As you can see, we are live from our event. So if we have any technology problems, please bear with us. And I promise you, we will resolve them as soon as possible. Tonight's event is available on Facebook, forever free of charge, but we'll also put it onto our woundcare-today.com website where you can watch it at your leisure, but also download the slides. Towards the end of tonight's event, we will make the link for your certificate of attendance available, which counts towards your revalidation portfolio, so stay around for that. I think it's fair to say, I think you'll probably agree with me, that the more engaged you are tonight, the better it will be for Siobhan and the event in general. So please make comments, please ask questions, and we'll endeavour to answer as many of them as possible towards the end of tonight's event. Two quick thank yous before we start. Firstly, to you guys. One, for joining us tonight. We know how precious your time is, but also to the thousands of people who've been to the mymicroworld.online website and have engaged in the first module and given your feedback. So thank you so much, because that feedback is pivotal to ensuring that we make this product as relevant to you, your colleagues, your patients and their carers. And secondly, to Myrmica. Myrmica are our UK and global partner of Microworld, and without your commitment and trust, these events simply could not and would not happen. That drive for independent content is pivotal to everything we're trying to do tonight, but across the year, so thank you so much. So without further ado, it gives me great pleasure to introduce you to tonight's speaker. Over to you, Siobhan.
Thank you, Ed.
Pleasure.
Hello, it's lovely to see you down the lens. It would be lovely to see you in person. It's been absolutely fantastic being here again, and I'm really, really proud to be asked to come and speak today on this platform as well. So my name's Siobhan. I'm a tissue viability nurse. I've had various backgrounds within the NHS for over 21 years. I've been a district nurse in the community, and I started my journey a very long time ago as a carer as well. And wounds is my passion. So I'm really, really happy to be here talking to you today. So today we're going to be looking at recognising the different components that make up Microworld. We're going to appreciate that Microworld offers a new animated way to learn. We're going to understand the role of wound exudate in normal healing, understand why wound exudate can be problematic, and identify and prevent problems associated with exudate, and understand the aims of exudate management. So what is Microworld all about? Well, we all learn in different ways, so it's really important that this is considered when developing educational materials. The Facebook Live by Joy Tickle and Jenny MacDonald on Microworld and wound healing elaborates on the 7 key styles of learning, which include visual, oral, verbal, physical, logical, social and solitary methods. So Microworld provides a non-traditional way to learn, embracing all of these techniques. On completing a module, it'll count towards revalidation, and it opens other learning areas of the site. Complex content delivered through fun, engaging, interactive animations, videos, games and illustrations. So, here are some of the characters you might see. If you didn't catch the first Facebook Live, which introduced Microworld, here is a recap of the characters. So who do we have? We have Gluco, short for glucose, the body's primary source of energy. We have Mr. X, fluid produced by the wound to maintain a consistent moisture level to bathe the wound. We have Mac the cleaner. Mac is a macrophage who detects, engulfs and destroys bacteria and debris, clearing up the wound. We have Newt, white blood cells which trigger tissue injury inflammation and destroys bacteria and debris. MC is a larger white blood cell that transforms into macrophages to clean up the wound. We have Scarlet, the red blood cell, the main cell of the blood, which picks up oxygen from lungs and delivers around the body. And Mr. Clotsworth, small blood cell fragments which cause the blood to clot. We have the controller, initially released by platelets on injury, but also by macrophages and other cells to stimulate healing. The pro-twin protease enzyme, an enzyme that breaks down proteins in damaged wound tissue. The pro-twin protease inhibitor. These enzymes ensure that proteases only break down damaged proteins. Yellow and blue, providing energy and resources needed for healthy wound healing. Fibroblast and microfibroblast, long thin cells which pull the edges of the wound together to speed up the healing process. So, just to recap, and as I mentioned earlier, the first Microworld class was launched earlier this year, and it takes you through the delicate process of wound healing, including the functions and anatomy of the skin and the 4 phases of healing. So here is a snippet of the interactive skin game.
Level 1, the epidermis. Comprised of dead flat cells, on most of the body it's thin, 0.1 millimetre, but 1.2 millimetres thick on your palms and the soles of your feet. The epidermis has no direct blood supply and receives nutrients and oxygen by diffusion from the dermis.
Great, isn't it? So this class is first as it's fundamental to understanding all aspects of wound care. So if you haven't already completed it, it is a great place to start your Microworld journey. So, back to the class we're focusing on today. This class on wound EXUDATE will take you through what EXUDATE is, EXUDATE in normal and abnormal wound healing, holistic wound and EXUDATE assessment, and management and prevention of complications, which I know we all see in practice. So the class starts by describing what happens when an injury occurs, inflammation. This is covered in more detail in Module 1, but we will recap here as it is the process in which EXUDATE production begins. So inflammation, the first stage of healing, is triggered on wounding. Inflammatory mediators, for example histamine, is released into the blood. Well, this increases permeability of the capillaries, and essential cells and molecules for healing pass through capillary walls into the wound. Well, the resulting fluid is EXUDATE. So, here is a short animation of the inside of the capillary, and you can see the lads in action. EXUDATE is an essential fluid that delivers all the components needed to start the wound healing process. Moist wounds heal 2 to 3 times more quickly than wounds that are allowed to dry out. So EXUDATE bathes the wound bed to prevent it from becoming dry. Clotting agents to stop bleeding on initial wounding. Nutrients that provide energy for cellular repair. White blood cells that clean the wound at different stages of healing. Growth factors that control healing activity. Protease enzymes that break down proteins in the wound. Protease enzyme inhibitors prevent proteases from being active once their job is done. Some wound types may produce more EXUDATE, such as venous leg ulcers, larger wounds and deep wounds. If an acute wound is healing properly, EXUDATE volume will be reduced as the wound heals. So understanding the stage of healing the wound has reached influences the volume of wound EXUDATE to expect. So in initial inflammation phase, more EXUDATE is required, and the granulation and epithelialization phases, less EXUDATE is required. Some patients and carers believe the production of EXUDATE is bad, so explain the important role of EXUDATE to educate and involve them at every step. They will feel part of the decision-making process and understand what you're trying to achieve. If a large volume of EXUDATE is produced, be proactive and ensure you protect the peri-wound skin before there are any signs of peri-wound moisture-associated dermatitis. If wounds start producing more EXUDATE than normal, it could indicate a change in wound status, such as infection or a change in the status of an underlying condition. This is why it is so important to not just ignore changes in EXUDATE volume outside of what you would expect for the patient, their wound and their stage of healing. In some cases, EXUDATE can delay healing. This is usually related to too little, too much, in the wrong place, and the wrong composition. So in phases of healing, the largest volume of EXUDATE is produced in the inflammatory and proliferative phases of wound healing. In hard to heal wounds, the inflammatory phase is longer, leading to prolonged exudate production. Systemic, for example, cardiac, venous and lymphatic disorders can result in excess exudate being produced. So underlying conditions need to be addressed to correct this. The locality, the size, depth, location of type of wound, wound infection and presence of devitalised tissue. Exudate from hard to heal wounds can have a really negative impact on the wound healing environment. The inflammatory process is prolonged, proteases that are normally carefully regulated become unregulated. And this means that exudate can result in damage, including the wound enlargement and delayed healing. So comprehensive assessment and optimal management of wound exudate is therefore paramount importance. So the peri-wound skin should be assessed for evidence of maceration, so when the skin turns soft and white with a wrinkled appearance, often talked like when you get out of the bath. Excoriation, fiery, red, inflamed, wet tissue that is often associated with pain. Erythema, or redness, a spongy texture and wounding. So poorly managed exudate can lead to pain, discomfort, leakage and soiling of clothes and bedding, odour and frequent dressing changes. Patients generally have a poorer quality of life and patients can become socially isolated and depressed. Tools are available to help undertake and document a holistic wound assessment, and this assessment should consider the wound bed. So when assessing the wound bed, pay particular attention to the presence of wound infection, biofilm, devitalised tissue and edema. These can all cause high volume of wound exudate. Take account of the peri-wound skin, exudate and odour. There are tools to assess odour, such as the Teller impact of odour scale, which considers how deeply the patient is affected by seeing if the patient is aware of the odour, concerned that other people will notice, reluctant to socialise, having trouble eating, for example their appetite is affected because of the odour, and maybe nauseated. Assessing exudate can be difficult in practice. So some key things to look out for are colour, odour, consistency and volume. Normal exudate is a clear or straw coloured and is fairly thin. When there are white cells and bacteria in the exudate, it becomes thicker, opaque and discoloured. A pink or red exudate may indicate the presence of red blood cells or a traumatic dressing change. So here we have a short clip that shows how Microworld covers this aspect of exudate assessments.
To assess exudate, there are some key things to look out for, including colour, odour, consistency and amount. Examining the wound dressing before and after removal gives an indication of the type of exudate and how the dressing is performing. Colour. Clearish, amber or pinkish red colour indicates normal and red blood cell present exudate. Cloudy, yellowy, brown or milky red and red indicates the presence of pus or a mix of blood and pus, which can be signs of an infection. Odour is also a good way of assessing exudate. Most wounds have some odour, but unpleasant and strong-smelling exudate may indicate infection or necrotic tissue. There are various consistencies of exudate. It can be watery, thick or sticky. Discoloured, viscous exudate may indicate wound infection. And volume of exudate, normal, excessive or not enough. It might be difficult to assess, but it is important.
So examining the wound and dressing before and after removal gives an indication of the type of exudate and how the dressing is performing. So note the wear time. Take a photo of the dressing pad on removal. Well, some wounds may have a low volume of exudate. If so, use a wound dressing that rehydrates the wound bed. With a large volume of exudate, protein is lost. A hard to heal wound can increase protein requirement by 250% and can increase calorie requirement by 50%. So this must be considered and protein uptake increased if a nutritional assessment shows that it's necessary to supplement. So clinicians who manage wound exudate effectively will aim to optimise the patient's condition and quality of life, manage wound-related symptoms, prevent or manage factors that contribute to the development or perpetuate of the wound and to abnormal exudate volume or composition. Consider patient preferences and provide patient carer education. Conduct further investigations and make specialist referrals when necessary. Optimise the condition of the wound bed and peri-wound skin. Achieve moisture balance and prevent and treat any other exudate related problems. Macerated skin has a higher pH than normal skin and is therefore increased risk of damage and bacterial and fungal infections. As some patients may have a high volume of wound exudate for a considerable length of time and the wound will not heal, for example, fungating wounds. Full therapeutic compression therapy for venous leg ulcers is likely to be effective in reducing exudate production. So choose the appropriate dressing for the amount and type of exudate produced by the wound. The dressing should contour to the wound bed so that the pooling of exudate is prevented. Absorbent dressings should be able to efficiently transfer exudate to prevent this pooling. And when required, the absorbent dressing should support a clean wound bed by absorbing and retaining exudate and microorganisms and promote otitic debridement. Total antimicrobials incorporated with efficient absorbent may be required when a wound biofilm or infection are present. And negative pressure wound therapy, or NPWT, can also be used to remove excess fluid from the wound bed. Low volumes of exudate may prevent migration of epithelial cells, so dressings that keep the wound moist have been shown to improve healing rates and reduce pain and infection. So protect the peri-wound skin from the effects of excess exudate with high absorbency and retention capacity dressings. You can use skin barriers or creams that can be helpful in protecting healthy skin from exposure to corrosive exudate. Adhesive dressings can damage delicate peri-wound skin and should be avoided. And use low adherent or silicone dressings instead. The patient should always be at the centre of any decision making when choosing a dressing. This will ensure it suits their needs and fits in with their daily life. And importantly, it will aid concordance and help to improve their quality of life. So be aware of how each type of absorbent wound dressing works, with gelling fibres, foams, sulfur absorbents all absorb and deal with exudate in different ways. Position the dressing to best absorb exudate, bearing in mind gravity can pull exudate downwards in some cases. So if you're using a secondary dressing over a primary dressing in a lower limb wound, place more of the secondary dressing under the wound to protect the peri-wound skin. Ensure that the size of the absorbent pad covers the wound and surrounding skin to offer protection to the peri-wound area. If a secondary dressing is required, ensure that the primary dressing used is capable of transferring fluid into it. So be mindful that the wrong type of dressing could hinder this. Using a waterproof filmed backed primary dressing will prevent the transfer of exudate into the second dressing placed over it. It's important to keep the wound bed moist to promote healing. And as the wound condition changes over time, so too will the dressing that is needed. Assess the wound and dressing at each change to ensure the right dressing is used to achieve moisture balance. So, we hope you have enjoyed the introduction to Class 2 on wound exudate and the snippets we've shown you here. When you reach the end of the class, you will get a brief recap on the content. Then you can take a quick test to find out what you have learned. And this is really useful for all nurses and carers and anybody interested in wound healing. So completing the module also opens up other areas of the site, giving you access to further content. You can also monitor your progress on your personalised dashboard, and you can access new content, view your activity, and visually track, monitor and analyse your performance all in one place. And here's an example of the dashboards. So to conclude, Microworld offers a new animated way to learn, catering for all the different learning styles. I hope this Facebook Live has helped you to appreciate just how important exudate is and that it is essential to the wound healing process. Remember too that in hard to heal wounds, exudate can have a negative impact on the wound healing environment, and the patient should always be at the centre of the wound assessment and the management plan. Thank you very much.
Brilliant. Thank you very much.
Thank you, Ed.
And thank you to everyone out there for your comments, questions, engagement. Thank you very much. So we've got a number of questions here. First thing, as Siobhan said, please go to the website. It's mymicroworld.online. We want as many of you to engage as possible. So do it later, do it tomorrow, but let us know your thoughts because we need your feedback to make it the best it can possibly be. Are you okay to crack on with the questions?
Let's go for it. Let's
Fantastic.
see what comes up.
So question number 1 is, how do you know when to select a super absorbent dressing?
Yeah, that's a really good question. They are very costly. So we are often asked when it comes to our wound formulary to take into account not overusing super absorbent dressings. So for me, for my patient, it's if the dressing that I'm using, the secondary dressing, just isn't effective in holding the amount of exudate. So it might be, we see a lot on venous leg ulcers, they get very, very wet. But actually with certain wounds, you don't want to be taking dressings off and on all the time. So it's really about containing that wound as long as possible, not removing dressings every single day. It's not good for nursing time, it's not good for the wound in most cases. So I think that for me is the key thing, about how long can we keep it on for? And actually in terms of cost effectiveness, it's sometimes more cost effective to use a super absorbent than it is to keep using a general sort of foam every day.
Fantastic, thank you.
Makes sense.
Thank you. So next question from Rob, thank you Rob, is who is Microworld content most relevant for?
Well, once you have a look at the platform, it'd be interesting to see what you think. I think every nurse, to be honest. I've done it as a tissue viability nurse, and it kind of refreshed for me as well. I've been doing this for quite a long time. The first module was brilliant for giving me a recap, but I think district nurses are kind of like mini TVNs, I think, out there in practice. Yep. And also practice nurses, which quite often don't always get access to educational platforms like this. Carers, you get informal and formal carers that are supported sometimes by district nurses in doing sort of basic wound care, not always basic, but you know what I mean. So I think carers, nurses, TVNs, district nursing practice nurses.
Yeah, and that's been our experience over the last few months when we look at the data as to who's engaged. It's been a really broad spectrum of specialists down through the everyday practitioner, but also carers, but also patients. Yeah. And actually one of the visions behind this was to create content that would be accessible for patients on social media, on the website, and I'm quite excited to see what the feedback's going to be.
Brilliant.
After this module.
Amazing.
So next question, how do you know when to ease off the way you're managing exudate?
I think when the wound's doing well, you know, when the wound's starting to repair, is healing, is contained, when you're going to the granulation stage. So anyone that looks at the stages of healing, you'll see it from the first module. The granulation stage is the happy stage. So as the wound is granulating, proliferating is next. So that's when we'll start remodelling. So if it's doing well, leave it alone, I would say. If there isn't anything that you're wanting to actively remove in terms of the exudate level, that's when I would ease back.
Okay, thank you. Next question, question 4. Is it possible to use an absorbent dressing that will debride as well? Won't it remove the fluid necessary for autolytic debridement?
That's such a good question, and it does become that help or hindrance in terms of getting the fluid balance right. So we know when it's too much because we get peri-wound maceration, and then we know we need to step it up to the next absorbent level because we'll use barriers in the peri-wound, but actually you want to remove that fluid, so that's when I would step it up. If the wound bed is then looking very dehydrated, you probably want to step it back on the super absorbent to maybe the foam. It might be that you're using a gel, a hydrogel or something underneath, in which case you don't want a super absorbent because that will just absorb into the super absorbent. So it is definitely about that balance, and that's why that's on our time acronym for a wound assessment, I guess. Yeah.
So thank you. So question 5, thank you all for the questions that keep coming in. Would you use a barrier cream, etc., for everyone with different levels of exudate?
Not necessarily with every patient. It does come down to that individual assessment. We deal a lot with pressure ulcers and sacral areas, people that might have incontinence as well, so you've got an extra pressure on the skin pH balance, so it might be for them, then absolutely I'd go for a barrier, but you could have somebody with a long-standing leg ulcer that actually their peri-wound area is quite dry and it wouldn't necessarily be needed at that point.
Fine, brilliant. Question 6.
I feel like I'm on question time.
No, don't joke. It's the suit is the problem.
It is, I
I should have
think
worn the
so.
t-shirt.
It's very official.
I should have worn the t-shirt. It's been 2 years
been
since
tested.
I've worn a suit, and it's so uncomfortable. And these shoes are horrific. Sorry, ladies and gentlemen. What else is available on Microworld? It sounds great. So thank you very much for saying that. Shall I answer that?
Yes, go for
So we launched our wound healing module a few months ago. The second module is just out today on EXUDATE management. We have 16 modules planned over a 3-year period in the pipeline. The next one is wound infection, which comes out early next year. But again, on our website, we have a whole feedback mechanism where we want to hear from you as to the content that's most relevant to you, to your link nurses, to your carers, and to your patients. So please keep talking to us. So thank you very much. Question 7. It's really hard to get time for education. Is Microworld quick to use? What do you think?
I did
engaged?
the first one on a train journey with my earphones in for half an hour, and it was brilliant. The other good thing is actually when I got to my stop, I was able to stop where I got to in my progress and then come back to it and finish it off when I got home. So you can stop and start it and do it in stages, which is great for any learning.
Well, I think we've learned the hard way over the last 5-10 years that traditional platforms that we used to rely on 100% aren't relevant all the time now. People simply don't have the time to read journals when they get home, to engage with 45-minute videos online. And I suppose the pressure was on us to create a product and a platform that was as easy to use and as accessible as possible. So all the videos are around 10 minutes long, but we're also condensing that into little chapters of the video, so you can dive in, dive out for 2 minutes, 3 minutes. We're also going to cut them into social media. So the idea is that nurses who are about to see a patient can see a 45-second clip to remind them, or play that clip to the patient and their carer to really bring alive what they're trying to explain, to help compliance, to help concordance, and also bring it alive. So the whole idea is it must be quick to use. And it's quite challenging to 49-year-olds like me who are used to big events like today, publishing journals, etc. But I know this has to be the way forward, not just in this country, but all around the world. So next question, please talk about how long dressings should be kept on, please, Siobhan.
Oh, wow. It really does depend on the patient. So I can't say, to be honest, this day or that day. It depends on the stage of their wound healing. If there's any district nurses, practice nurses, I know you're all going to be thinking the same thing of leg ulcers, and if someone's in compression, we try and go for a week, for example, which seems like a very long time. And actually, when we talked earlier on about concordance, there is a lot of family members feel quite uncomfortable about a wound dressing being kept on for a whole week, especially when it's the exudate's starting to show on maybe the pad, and they think actually that's the time it needs to be changed. So it really varies. If it's a leg ulcer and they're in compression, it might be a week. If it's a surgical patient and you're concerned about cellulitis or spreading infection or surgical site infection, it'd be every day. So it really does depend on the wound. Sorry, I can't give a definitive answer for that.
So next question. Thank you for the questions that keep coming in on my iPad here. Compression is fantastic for managing exudate, but for a person who can't have compression, how would you manage high levels of exudate that is macerating the surrounding skin? It's a
really good question. There are some people with venous disease or peripheral venous disease or arterial disease that can't have compression but still are kicking out quite a lot of exudate. I mean, personally as a TVN, I do go for my super absorbents for these patients, and I recognise that they take an awful lot of a bite out the budget. I think it depends again if you're in acute or a primary care setting. If you're in a primary care, it might need to go a little bit longer, and you can go for the more expensive super absorbents that really contain. For me, in a large general, quite often we'll use a sort of cheaper product but change it more often, but that's not always viable in the community if you've got a district nurse visit twice a week. So it does depend where you are, but for leg ulcers that can't have compression, I always go for these super absorbent, just pads, really.
Brilliant, thank you. So next question, can you remind us, Siobhan, about the colour of exudate and what it means?
Yeah, so we talk about hemocyrus sort of exudate really, and that's your kind of straw sticky, because platelets is quite sticky, so that's kind of your strawy sticky exudate. And then you've got hemocyrus exudate, which is more blood stained, which sometimes again might be a bit normal as the capillaries are healing, but in some cases it can indicate some trauma. And then you've got very thick, fluffy and which is what we're all used to as nurses. We see a lot of sloughy wounds. Slough is just dead white skin cells really that are just adhered, and that's the proteases that are there to really come and sort of clean them up. That's how I always think of the macrophages. They're coming along with kind of a broom and cleaning up the area. So they're kind of the three main bits of exudate you'll see.
Brilliant, thank you. This is a good question. How do I cope with exudate if my patient is lying on their wound?
Oh gosh,
Yes.
I've really been put through my paces,
Yeah,
aren't
no.
I?
Let's relax again
Yeah.
to a really stress-free day.
I mean, yeah, that's a difficult one, guys. If you can move them, if they're able to be repositioned, then, you know, obviously you on dressing change, you would put a new pad on or a new super absorbent. If they're lying on it, it's always difficult for wounds to heal anyway, but just because the level of pressure. Anybody that deals with pressure ulcers and talks about pressure ulcers know that we try and take the pressure off to facilitate healing. So my first thing I'd recommend is micro-tilting where you can, or micro-tilts off the affected area, but otherwise the dressings really need to take into account the containment. So again, going back to your super absorbents.
Yeah, thank you. What about if there's no exudate in a wound? Is that a good sign?
I'm sure we've all heard from our grandmothers, mothers, I'm leaving my wound open to heal.
Yeah.
I'm leaving it open to the air will heal it.
Yeah.
No, we need a good moisture balance for a wound to heal. If it's fairly superficial, it may do okay on its own, but anything below the epidermis, going to the deep dermis, it'll need a moisture balance to enable that healing, that proliferation. That's my proliferating cells, by the way. Yeah, healing together.
Now, I had a granny who I miss massively who had something she called puffer.
Yeah.
To this day I don't know what it is, but it's like a pink puffy dust that she used to puff onto my grazes, my endless grazes.
Pink puffy dust?
Come and put puffer and then leave it out, it out.
Oh,
And
I've
so
never
I was
heard of that.
utterly shocked that she'd got it completely
Is that what the
clinically
pink
wrong.
ties are made of?
No,
From memory.
not in any way, shape or form. So next question, what's the link between highly exuding wounds and infected wounds?
Well, infected wounds can become, you can have more exudate, but you need to look at the other clinical signs for infection. So it might be odour, pain, heat around the area, obviously looking at their systemic factors, so increased white cell count or CRP or corrective reactive protein, if they've got a temperature. So I would look at those other signs which are obviously you need to be able to monitor somebody's observations. But highly exuding wounds can be an indicative factor of that infection, but sometimes you do just get a very highly exuding wound like a leg ulcer that doesn't necessarily mean it's infected, and we're all working very hard with our antimicrobial stewardship to not offer systemic antibiotics in those cases, so you need to make sure that you are pretty convinced that it's infected.
Brilliant, thank you. So we're down to our last two questions. Okay. How do we educate our patients about exudate?
It's a great question. I think we're all doing it regularly. I think allowing them to know that it's a normal part of wound healing, that it's a wound process. I often go back to my macrophages or white cells sticking, and then my macrophage coming along with a broom and sort of sweeping them all up. That actually kicking out exudate can be a good sign of the wound, that at least there's vascular supply to that area. And that's where Microworld's really good for showing the little animations of that, because it just helps. So I use Microworld if you can, to sort of promote that, but also finding a way to explain that they are confident about.
Well, I think it's so important to involve them in the process. I certainly feel slightly guilty over the years that we just simply haven't engaged with the patients and their carers enough.
Yeah.
You know, we talk to ourselves in wound healing communities all around the world.
Yes.
But very rarely, do we have patients at events.
Yeah.
Very rarely do we hear their voice. And I think we should try and change that.
We treat the whole patient, not the hole in the patient.
That's correct. Correct. Professor Harding will be proud of you and proud of me that we got that in. So
old school.
Yes, exactly. So our last question. How hard do you think people find it to understand exudate, and how much education should I be sharing with my team?
I think ask them first, gauge it. What's your understanding of exudate? A lot of the feedback I get is that anxiety from patients and carers about seeing exudate on the wound dressing. They'll want it changed at that point, or they're worried that it's infected. So you guys are asking, I think, the questions you're asking because that's what you're hearing in practice too. Yeah. So I think it's just normalising the term around exudate, and start with this sort of education really, just to raise that awareness.
Thank you. Genuinely,
thank you
for everything.
No worries.
Ladies and gentlemen, thank you so much. That concludes tonight's event. The link for the certificate of attendance should be available now, so please download that because that counts towards your revalidation. Please go to mymicroworld.online. do the EXUDATE module. It takes 10, 11 minutes. We'd love your feedback. Thank you for your questions. Thank you for your comments. It means a great deal. Just a few thank yous to the team here now. You can't see behind this camera, but to everyone involved at Wound Care Today and at Mole Digital. Thank you for putting on an incredible event. Massive thank you to you, Shiv.
No worries.
Thank you so much for tonight. Again, a big thank you to Manika for your support. It's hugely appreciated. And last but not least, to you guys for tuning in. You know, it means the world that you engage. It means everything to us that you choose to join us for these educational sessions. So thank you so much. Have a great night. Stay safe, stay strong, and we'll see you very soon. Thank you very much.